So these are the three broad topics we're going to be talking about: imaging, biomarkers, and genetic testing, and lastly, the newer medications that are available to us. So first up, imaging. So what do we have available for imaging prostate cancer? Really, localized prostate cancer is not that much of a challenge to us, because when we have patients with very low PSA levels, low Gleason scores, and benign rectal exams, our local imaging really doesn't help us that much. In fact, if you look at AUA guidelines, imaging is really not necessary for most patients with a PSA of less than about 10 to 20 or low-risk prostate cancer. However, where imaging is very important is when we're worried about advanced disease states. And our standard imaging that we use for a long time in determining if a man has advanced disease is our usual technetium bone scan and a CAT scan or an MRI. We're coming into a very exciting time right now. Although next generation PET imaging has been with us for several years, the very exciting area that we'll address will be PSMA targeting and PSMA-based imaging. Lastly, we're just going to briefly mention whole body MRI, because while a whole body MRI is commonly done in Europe, it's not too widely done here in the United States, and it's very effective at detecting bone metastasis. But I think you'll see as we go through this first part of of this lecture, you're going to see how important PET imaging has really become. So the standard imaging methods for the detection of prostate cancer spread is the bone scan. Again, a man has to come in, be injected, and then come back several hours later. A CT scan exposes patients to 60 times more radiation than an X-ray. And again, we have concerns about repeated exposure. Although, to be fair, for the typical population that we may be dealing with in prostate cancer, this may not be as critical as for younger patients. But nonetheless, there's always the theoretical advantage or disadvantage of exposing a man to unnecessary levels of radiation. So the CAT scan for looking at advanced prostate cancer, what's good about it? If nodes are involved, usually less than 1 to 1.5 centimeters, we can usually detect it. Unfortunately, nodes that are not enlarged above 1 centimeter may harbor cancer, and that's where we're going to see later that PET scanning may help us. And of course, if you have metastasis to solid organs like the liver or to the lung, and again, spread of prostate cancer in advanced castrate-resistant to the disease can be seen in the lungs. What's the downside? Well, a CAT scan is not particularly good at picking up bony lesions. And again, limited detection for nodal metastasis with a sensitivity of less than 40%, but a specificity which is much higher of 80%. And again, that relates to enlarged lymph nodes in the setting of prostate cancer. What about our old standby technetium-99 bone scan? Well, it is highly sensitive for osteogenic activity. And as you all know, prostate cancer tends to be very strongly osteogenic. It's good for a quick assessment of the whole skeleton from the top of the head to the bottom of the feet. However, it does have low specificity, only moderately sensitivity, particularly at lower levels of PSA. And we talk about lower levels of PSA, we're talking about levels of less than 10 to 20 nanograms per mil. Now, one of the things that you may have heard about is an initiative, the American Board of Internal Medicine Foundation, which is actually located here in Philadelphia, just down the street from Jefferson, really is pushing avoiding imaging in low-risk prostate cancer. And this is also consistent with the AUA guidelines, where if you have low-risk prostate cancer, there's really no reason to do imaging because it can give you potentially harmful radiation. But again, incidental findings may cause you to do other procedures. And again, if you have low-risk prostate cancer, low Gleason score, low clinical stage, low PSA, you can probably skip doing a bone scan. Now, what do we have guideline-wise? Well, the Prostate Cancer Clinical Trial Working Group weighed in on castrate-resistant prostate cancer. Again, this is not initial staging, but this is when you've identified somebody with castration-resistant prostate cancer. So now we're moving to more advanced stages, and this is what they recommended in 2016, CAT scan of both the chest, abdomen, and pelvis. Again, Advanced castrate-resistant prostate cancer can involve pulmonary lesions, and that's something we tend not to think about a lot. Bone scan, of course, is necessary at baseline. Interesting, if you've got neuroendocrine tumors, very high Gleason 9 to 10 cancers that perhaps stain for neuroendocrine factors, think about a baseline MRI of the skull. And again, based on this rising symptoms, they recommend re-imaging anywhere from every 3 months to 12 months based on the rise in the patient's PSA and symptoms. Now, I was fortunate to participate in something known as the RADAR series. And what the RADAR 1, 2, 3, and 4 brought together an interdisciplinary group of urologists, medical oncologists, radiologists, radiation oncologists, and talk about a little more granular detail on imaging. And RADAR stands for the Prostate Cancer Radiographic Assessment for the Detection of Advanced Recurrence. And basically, these were the guidelines that were in our 2014 paper for RADAR 3. If you've got a patient with new diagnosis, if the PSA is greater than 10, they have a high Gleason score where they have palpable disease, consider imaging. For patients who have biochemical recurrence after local therapy, you should consider doing a first scan and a PSA between 5 and 10. And again, depending on the doubling time, you may want to stretch that out a little bit. And lastly, a new area, the M0 castrate-resistant prostate cancer, is a little bit different. And one of the reasons the M0 castrate-resistant patients are a little bit different is we now have at least 3 different medications: darolutamide, apalutamide, and darolutamide, enzalutamide, and there's a third one out there. I'm having a senior moment. But we have these medications, 3 medications right now to use in the M0 castrate-resistant space. And these patients may benefit from early detection of micrometastatic disease and go on one of these androgen receptor pathway blockers, such as darolutamide, apalutamide, or enzalutamide. Next generation imaging. This is the very exciting area, and this has been brewing for a while, but with the recent approval of PSMA PET scanning, we have a much better opportunity to see things that we wouldn't be able to see using standard bone scan or a CAT scan. And they have great not only diagnostic potential, but we'll talk about in a few minutes, therapeutic potential. So the PET scans, what's different? What's a PET scan? Well, a PET scan is known as next generation imaging. And what a PET scan does, it's usually fused with something such as a CAT scan to give you both a molecular analysis, a metabolic analysis, and annotated imaging. It allows quantitation of the intensity of the signal, and it gives you the opportunity to maybe do more focused biopsies of areas that you detect in the body. So here's the basic background of prostate cancer PET scans. Basically, what you do is you take a prostate cancer avid molecule, a molecule which tends to be elevated in prostate cancer. And we'll talk about the subtle difference between acetate, choline, flucyclovine, and the PSA analogs. You connect that with a positron emitting tracer. The tracers that we commonly use are C11, F18, and gallium-68. You take those combined molecules, you infuse them, and then after you get the PET image, you fuse it with a CAT scan or MRI. So you not only get the metabolic signature of the cancer, but you also get the anatomic location where it is located. So the radio tracers that we link to these avid molecules are, again, carbon-11, F18 fluorine, or gallium-68. They're all subtly different. I point out one of the challenges with the carbon-11, which has actually been with us for quite a while. You really need to have a cyclotron on site because the half-life of that radio tracer is quite short. It's only 20 minutes. F18 is a little bit more forgiving. You need a cyclotron, but the half-life is about 5 times as long as it is for the C11, so you can have a cyclotron across town and deliver the tracer. One of the exciting areas about gallium-68 is you can have your own generator in your nuclear medicine department, and through the magic of physics, generate your own gallium-68 right on site, and then use that to administer to the patients. So everyday PET. Everyday PET is known as 18F-FDG, and that's fluorodeoxyglucose. This is the standard PET scan that's been with us for a long time. Used for a lot of cancers, very useful, but not particularly beneficial for advanced prostate cancer because of the low glucose metabolism. Occasionally, if you've got advanced metastatic castrate-resistant disease, it may be useful. But in general, an everyday PET is not particularly helpful for us in dealing with prostate cancer. When you look at the different prostate cancer PET imaging agents, you can see the 6 of them here: the F18 FACBC, the C11 choline, the gallium-68 PSMA. But I want to point out these orange ones here, as we'll talk about at the end. There's different PSMAs. There's just not one PSMA scan out there. Right now, the one that got the first approval, though, and the most excitement is this gallium-68 PSMA scan. Lastly, we have C11 acetate, and we'll talk a little bit about each of these different scans.